Okay. Once again, welcome everyone to today's session of the R3 seminar series, Characterizing Long COVID in Early Childhood. My name is Patrick Ahern with RTI, and I'll be helping out with the virtual room today. So just a few quick housekeeping notes before we get started. Note that when you log in, your microphone and web camera are automatically muted. If you have any questions for our presenters today, please submit those into the Q&A window at any time. And if you run into any technical issues with Zoom, please let me know in the Q&A window as well. Closed captions are available during today's webinar. Just click on the Show Captions button on your main Zoom toolbar to turn those on. Towards the end of today's session, we will launch a brief feedback poll, and the Recover team would greatly appreciate your responses. So at this time, I'll go ahead and turn things over to Christine to kick off today's session. Thank you.
Thank you, Patrick, and welcome everyone to the Research Review, or R3 seminar. My name is Christine Bevick. I'm a Senior Analyst and Study Manager with the Recover Administrative Coordinating Center here at RTI, and I'll be your moderator for today's session. The goal of this seminar series is to catalyze a shared understanding of the research within the Recover Consortium. I want to start by thanking everyone who submitted questions in advance and remind you that you can submit your questions at any time during today's presentation using that Q&A feature that Patrick mentioned. It's located down there in your Zoom menu. After today's panel, our speakers will be answering as many questions as possible, and we'll be posting a Q&A document with a recording of the seminar on recovercovid.org. The questions will include answers for submitted questions relevant to today's presentations, and questions about other topics will be addressed in future seminars, and answers to broader questions about Recover will be available on our general FAQ, again found at recovercovid.org. As a reminder, throughout today's session, we cannot answer any questions about individual clinical care. Joining us today, I am pleased to share that we have Dr. Rachel Gross, Dr. Tony Tawitai, Krista Combs, Megan Carmilani, and our discussant will be Dr. Amy Salisbury. Dr. Rachel Gross is a general academic pediatrician, a clinical research investigator, and an associate professor of pediatrics and population health at the NYU Grossman School of Medicine. She's the principal investigator and director of pediatric research for the Recover Clinical Science Core, leading implementation of the Pediatric Observational Cohort Study. Joining Dr. Gross today is Dr. Tony, as we call him, Tawitai. He is the Associate Director of Biostatistics, Research and Engagement at Massachusetts General Hospital Biostatistics, and an Assistant Professor of Medicine at Harvard Medical School. He's also an instructor in the Department of Biostatistics at the Harvard T.H. Chan School of Public Health, and currently serves as the lead statistician for the Data Resource Core for Recover. Krista Coombs joined the Recover Initiative in 2021 as a caregiver representative and is serving on several working groups. She's practiced traditional Chinese medicine for nearly 20 years, treating both children and adults, bringing both clinical and personal experience to this work. Krista is a parent of 2 children affected by long COVID and tick-borne illnesses, living with long COVID herself. She currently works at the Vermont Center for Independent Living, focusing on advocating for and supporting peers in Vermont affected by long COVID and SARS-CoV-2. Megan Carmilani is the founder and president of Long COVID Families, a nonprofit organization that supports children with long COVID and their families. She's a member of the Recover Pediatric Coordinating Committee and contributes to the Recover National Community Engagement Group, leveraging her experience in patient advocacy and personal insights from her own struggles with chronic illness, both helping to guide her advocacy efforts and ensure children's needs are addressed in both research and healthcare. Amy Salisbury is a professor of the Stigletter Endowed Chair for Research at Virginia Commonwealth University, where she serves as the Associate Dean for Research, Scholarship, and Innovation in the School of Nursing and Director of Research for the Institute for Women's Health. Dr. Salisbury currently co-leads a 3-site hub for the Recover Pediatric Cohort. So today's panel, as Patrick indicated, next slide. The topic is characterizing long COVID during early childhood. Our speakers will present findings from the Recover Pediatric Cohort study, identifying long COVID symptom patterns in infants, toddlers, and preschool-age children. Panelists will also share family perspectives about the study findings. So with that, please welcome all of our speakers, and I'll turn it over to our first two, Dr. Rachel Gross and Dr. Tania Tawitai.
Hey, thank you so much. Good afternoon, everyone, and thank you so much for having us here today to share with you updates from the Recover Pediatric clinical cohort studies. And in particular, we're really excited to share with you our most recent findings on characterizing long COVID in early childhood. So this slide gives you a summary of our agenda for really the next 30 minutes. And we're going to start with a brief background on what is known about long COVID in children, as well as some background about the Recover Pediatric study generally. Then we're going to spend the majority of the time sharing findings from a recent publication in JAMA Pediatrics on characterizing long COVID in early childhood. And then we'll finish by highlighting some next steps for our Recover Pediatric study. So, what is currently known about long COVID in children? Most of what we know about long COVID comes from studies of adults. And when it comes to long COVID in children, there are many more questions than answers. The gaps in our knowledge really stem from several common misperceptions, specifically the misperceptions that children do not get long COVID, and if they do, their symptoms must be the same as those in adults. And we know now that these two statements are not true and have led to the under-recognition of the public health crisis facing our children today. So what do we know about long COVID in children? In 2024, the Recover Pediatric Cohort investigators, in partnership with the Recover Electronic Health Record investigators, came together and published a review article in Pediatrics. And this review article really highlighted that similar to adults with long COVID, children with long COVID can have exacerbation of their underlying conditions. They can have persistent symptoms that develop during their acute SARS-CoV-2 infection, or they can develop new symptoms or new conditions after their acute infection has resolved. This review also highlighted that similarly to adults, long COVID can affect almost every organ system of a child's body. In addition, the Recover electronic health record studies have contributed substantially to our understanding of long COVID in children and using existing retrospectively collected data from the medical record. And while they have many publications, I just wanted to highlight two that really focused on identifying children with long COVID. First, they began to develop and validate algorithms to accurately identify long COVID cases using the medical record. And they also did another study which identified different types of long COVID in children. Some children having more cardiorespiratory, musculoskeletal pain, neuropsychiatric symptoms, gastrointestinal symptoms, headache, or fatigue. And so you can see from this picture that the different colors represent children where their primary symptom might be different from each other. And so these studies started to give us clues that we need to understand better what's happening in children and that there are many similarities to adults, but there may be differences. And so while these studies documented different types of long COVID in children, we wanted to supplement them with studies where we're following children over time because they may be limited in the data that we have in medical records. And they're also limited in needing a child to go to the doctor to collect that type of data. In addition, other gaps in the pediatric evidence were noted. In addition to studies from medical records, most of the studies following new children with long COVID have been small. And so they've required us to combine all ages into a single group. And that hinders our ability to understand life course differences or age differences in children. In addition, prior studies have lacked adequate comparison groups. And so it makes it unclear whether prolonged symptoms in children are related to the SARS-CoV-2 virus itself or more broadly to the pandemic when we don't have adequate children to compare to. And so these limitations have limited our knowledge about the prolonged symptoms across the different ages in childhood and challenge our ability to identify, manage, and ultimately create treatments for long COVID, which is our overall goal. So Recover was really designed, our observational study was designed to fill these critical gaps. So how does it do that? Well, as you know, Recover stands for Researching COVID to Enhance Recovery. And its overall goal is to be able to understand and learn about the long-term health effects of COVID so that we can prevent and treat long COVID in children. And we're going to share with you results from our observational study where we're collecting data so that we can better understand how to develop these prevention strategies and treatments. And so what we have done, Recover Pediatrics has brought together 4 cohort types in what we call a meta cohort with sites at over 103 sites around and throughout the United States. And this includes what we call the main cohort, which consists of participants newly recruited into Recover, ranging all the way from infancy through young adulthood. And it also includes existing groups of children that are already in other studies, the primary one being the ABCD study of adolescents, as well as other children, young children who were exposed to SARS-CoV-2 during pregnancy, and as well as a cohort with a history of MIS-C. And most of the results I'm going to talk to you about today come from the young children in our main cohort. But to date in Recover Pediatrics, we have over 22,000 participants contributing data to the overall mission. And this is a very diverse cohort with 8% identifying as Asian, 14% identifying as Black, and 28% identifying as Hispanic. And this cohort comes together to help us address 3 overall aims. The first is to characterize the spectrum of clinical symptoms of long COVID across the ages, including to identify distinct phenotypes or different types of long COVID, and to describe the clinical course and recovery over time. The second aim is to identify risk and resiliency factors for developing long COVID and from recovering from long COVID. And the third is to define the pathophysiology, including subclinical organ dysfunction, and to be able to identify the underlying biologic mechanisms that lead to long COVID, so we can ultimately develop targets for treatment. So for this talk, we're going to focus on the first aim, where we're talking about how do we characterize the clinical symptoms of long COVID across the different ages. And I'm just going to highlight a study that we published last year that was published in JAMA. That was a manuscript looking at how we characterize long COVID in older children. Specifically, we started with school-age children and adolescents. And what we found overall was that while symptom patterns can be similar across these ages and similar to adults, there are distinguishable differences. So in these 2 age groups, we found that symptoms did occur in almost every organ system of the body, and that while there were many symptoms that were similar across the 2 ages, there were distinct differences. And so in the middle column, there were 14 symptoms that were more common in children who had a history of a COVID infection when we compare them to those who did not in both the school-age children and the adolescents. And there were 4 symptoms common mostly in the school-age children and 3 additional in the adolescents. And when we started to look at children um, who were more likely to have long COVID, we developed a research index to help us identify the school-age children and the adolescents who were most likely to have long COVID. And we use these indices to help us identify different symptom clusters or different types of long COVID. And what we found was that 2 of these clusters, the ones found in the middle, were similar in both school-age children and adolescents. One where children experienced many different symptoms across many different organ systems. A second, which was predominated by the experience of pain, fatigue, and low energy. And we found 2 unique clusters in school-age children. One characterized predominantly by trouble with sleeping and trouble with memory and focusing, and another characterized predominantly by stomach pain, nausea, and vomiting. And finally, in the adolescents, we had a unique cluster which was primarily experiencing change or loss in their smell and taste. But this led us to really think about, what about young children? What about our infants, preschool age, infants, toddlers, and preschool age children? What does long COVID look like for them? So I'm going to turn it over to Tony to talk to you about our most recent findings from our JAMA Pediatrics paper.
Thanks, Rachel. So I'm very happy to present the findings from from this paper that really, extend the findings of the paper that Rachel and I had the pleasure of presenting last year in the R3 seminar series to looking at children who are ages 0 to 5 years old. So really trying to understand the symptoms of long COVID during early childhood, specifically trying to understand what symptoms characterize long COVID in this age period and whether these symptoms are really different from that experienced by children later on. So there were numerous challenges that were presented to us as we began studying long COVID in early childhood. It's challenging because there are rapid developmental changes that occur. So children change rapidly between infancy to toddlerhood. And there's also very limited verbal communication. So identifying symptoms that very young children have means that we have to rely on caregivers to observe, identify, and interpret symptoms. Whereas, in the prior paper that Rachel described, children were able to, all the surveys were completed by caregivers, but they could be completed kind of together with the child, especially with adolescents. These results, these symptoms that these youngest children were experiencing were reliant almost entirely on symptoms that caregivers are observing, identifying, interpreting, and then ultimately reporting in the symptom surveys. So, the importance of this study is that incomplete knowledge that we have in the scientific community about what symptoms persist after initial SARS-CoV-2 infection, if we don't know what symptoms are prolonged and last, then that can hinder our ability to prevent and treat long COVID. And this is a very substantial gap in our understanding of long COVID as a whole, but also long COVID in pediatric populations, since early childhood is such a critical period in setting lifelong health trajectories. Next slide. Thanks. So the 2 objectives of this paper were to identify common prolonged symptoms and how these symptoms vary by age group. So all of our analyses were split between infants and toddlers, those aged from birth to 2 years, and then preschool age children, defined as being aged 3 to 5 years. And then, in addition to identifying which symptoms were characteristic of long COVID, we tried to determine which symptoms in combination could be used as an empirically derived index to help researchers consistently assess the likely presence of long COVID based on caregiver-defined symptoms. So our intention was to use this as like a research tool to assist with research in identifying and studying long COVID. So towards this first objective, we used a statistical approach that involved calculating odds ratios to evaluate whether SARS-CoV-2 infection, which is the predictor, was associated with each individual symptom that was studied in RECOVER, adjusted for sex and race ethnicity. So if we go to the next slide, this is a slide summarizing the study design of RECOVER Pediatrics, where we had an infected group and an uninfected group, and we were comparing the symptoms reported between these two groups. The idea being that we wanted to understand which symptoms were uniquely associated with a history of having COVID. So this allows us to, by having this comparator group, this allows us to really identify which symptoms were uniquely associated with COVID rather than just kind of pandemic era effects. So we compared those with a history of infection versus those without a history of infection to understand which symptoms were indicative of long COVID. Next slide. So here's a little more information about what the symptom survey looked at. So the comprehensive symptom survey, which was remotely given to caregivers with interviewer assistance if needed, use health literacy informed principles in plain language descriptions of symptoms. And so the symptoms that were asked about were age appropriate. And of course, we asked the caregivers, and the symptoms that were included in this analysis were those that lasted at least 4 weeks and started or worsened since the beginning of the pandemic, and that were still present at the time of the enrollment survey. And so we included children who for whom at least 3 months had passed from their first COVID infection to when they completed the survey. So we were really looking at symptoms that were persistent or prolonged for at least 3 months after their initial infection with COVID. And so the symptoms that we looked at were, there was a lot of data that we worked with. There were 41 symptoms that we looked at in infants and toddlers, and then 75 symptoms in preschool age children. So this table from the manuscript summarizes the demographic characteristics of the children who were included in the analysis. So you can see that there were just under 500 infants and toddlers, and then just over 500 preschool age children, split here between those who did and did not have a history of SARS-CoV-2 infection. You can see that the population was about 50-50 male-female, sex assigned at birth, and that the cohort was also fairly diverse, with high representation of especially Hispanic, Latino, or Spanish children. Many lived in medically underserved areas, and there was a mix of individuals who were infected before December 1st, 2021, and those who were infected afterwards. So that means that we were looking at children who were likely to have been infected by initial variants of COVID, including the original variants as well as later variants, including Omicron. So it wasn't a cohort that was like predominantly one or the other. Next slide. So here is a summary of our findings related to which symptoms were indicative of having a history of SARS-CoV-2 infection and therefore characterized long COVID. So here we're looking at children ages 0 to 2, and we found that infected children had greater odds of several prolonged symptoms compared to those who were uninfected, including here trouble sleeping, poor appetite, fussiness, as well as these ENT, ear, nose, and throat, or respiratory symptoms, including dry cough, wet cough, and stuffy nose. So really, in total, there were 6 symptoms that were much more common in infected than uninfected infants and toddlers. So these were observed to be really elevated in children who had a history of COVID. Here, for preschool age children, those aged 3 to 5, we found 2 key symptoms that were more common in infected than uninfected preschool age children, which included daytime tiredness and sleepiness or low energy, and then dry cough specifically, finding quite large adjusted odds ratios for these 2 comparisons. So what we found is that these specific symptoms were more common in infected than uninfected children and are likely to indicate long COVID. Next. Yes. So with that information, though, so just looking at the symptoms, what we wanted to do was to be able to create a empirically derived index that could help researchers assess the likely presence of long COVID. And so we used, in this case, LASSO, which is a statistical technique to identify which of these symptoms is the best at identifying children who have a history of SARS-CoV-2 infection. So is there some sort of, what we tried to do is we tried to develop a method that can be applied, a research tool that can be applied to look at several symptoms at the same time in order to identify children who are most likely to actually have long COVID rather than just looking at symptoms individually. So here's a summary of the long COVID research index that we developed for these two age groups. The left is the infants and toddlers, and on the right is preschool age children. So on the left, you can see that 5 of the 6 symptoms were selected and are part of this long COVID research index for children in this age group, which includes the symptoms listed here. Each symptom is also associated with a score ranging here from 5 to 0.5. And in order to apply this long COVID research index to an individual child, you would add up the scores for the symptoms that are present in a prolonged fashion for that child. So present and persistent for at least 4 weeks. And then if the sum of the scores is at least 4, then they would be categorized as long COVID probable. And then if less than 4, they would be long COVID unspecified. And you could apply the same rule or the same methodology to the preschool age children on the right, where a score of at least 3, really having a score of presenting with either of these symptoms as being indicative of having long COVID based on symptoms that were present. And so importantly, this index is really intended to be used as a research definition. Our intention is not for this to be used for clinical diagnosis, but rather for researchers to be able to identify children in research studies who have long COVID to advance research going forward, and also to show that these are important symptoms that may be explained by long COVID if observed in children as symptoms that children are experiencing. Next slide. So, the symptoms that are presented in the long COVID research index, it's a short list, but as you recall, we asked about a very large number of symptoms, over 40 in infants and then over 75 in preschoolers. And so this figure shows a heat map of the proportion of individuals in 3 different groups in each of the age groups. So on the left, you can see 3 columns for infants and toddlers, that there's the uninfected group, then there are infected children who don't meet the criteria for being long COVID probable according to the research index, and then the 3rd column is children who are long COVID probable according to the research index. So what you can see is that the children who are classified as long COVID probable according to the research index, they don't only have the symptoms that are part of the research index, which are indicated with those blue dots. They also have other symptoms, including hyperactivity, phobias, fussiness, nightmares or night terrors, etc. And the children who don't meet the research index have much lower levels of these symptoms and other symptoms that are noted here in this figure. And the same story plays out on the right side as well, that the infected long COVID unspecified group looks similar to the uninfected group, but really, even though we only used the presence of either of the 2 symptoms with the purple dots on the right, even though the long COVID probable group was defined only by those 2 symptoms, these children still had higher levels of all these other symptoms that we looked at, suggesting that this index performs well in terms of capturing, so to speak, children who have other symptoms that are present in this prolonged fashion. Next slide. Thanks, Rachel. So the other thing that we looked at was whether the research index was correlated with worst PROMIS scores. So PROMIS scores are part of this survey, which is a standardized instrument that the caregiver can use to report on the child's overall health, quality of life, physical health, and whether the child is meeting developmental milestones. So I won't go into every figure here, but the idea is that within each of these tables, the columns refer to going from left to right, increasing long COVID research index, and then the rows indicate how well the child is doing on each of these PROMIS metrics. And what we generally see is that children with higher research indices tended to score worse on these self-reported quality of life, health, et cetera, metrics, suggesting that their long COVID research index really does correlate with quality of life as measured in these different ways. Next slide. So this figure summarizes the key findings of this manuscript. On the left being the symptoms that are most experienced by children with a history of COVID in infants and toddlers, and on the right, those in preschool age. And you'll note here that the symptoms reported here are quite different from the symptoms reported in school-age children and in adolescents, as was reported in the figures that Rachel showed earlier, indicating that a method for identifying long COVID needs to be tailored to the age group, since long COVID does appear to be different across the age spectrum. Next slide. So to summarize, the Long COVID Research Index is intended as a framework for future research studies. One thing that's been holding back research is that it's very difficult to identify some children with or without long COVID on the basis of their symptoms. And so it's our goal to utilize this Long COVID Research Index in future studies to better understand the causes and how to better prevent and treat long COVID in this age group as well as other age groups. And it can be used to study the underlying mechanisms as trajectory of long COVID over time. We're able to now apply this research index to longitudinal settings where, these children in our study are being followed longitudinally over time, and we're able to compare the symptoms that they're experiencing from visit to visit. And as children transition between age groups, we can also understand how the long COVID research index changes as the children get older in the study. Importantly, the research index is not intended for clinical practice. It may be the case that having just one of the symptoms that were indicated may be sufficient to indicate long COVID in any given child. And so it is not our intention to rule out long COVID for a child who is in need of help. The index is therefore no way intended to minimize the importance of the many other symptoms children with long COVID may be experiencing. These are just the symptoms that were selected to develop a parsimonious methodology for researchers to use in understanding long COVID. And finally, we believe this is an important first step towards a future tool to identify long COVID in children. And we expect this to change and develop as researchers learn more, as we collect more data, and so on. Finally, I wanted to mention a couple of limitations of the study. Symptoms were caregiver reported, which makes recall bias possible, as caregivers are asked to remember, whether a symptom has lasted at least 4 weeks, and if it really got worse compared to, prior to the pandemic. And for children who were enrolled in Recover more recently, this may be a couple of years since their first COVID infection occurred. And the next steps of our work are to incorporate other data, not just symptom-reported data, such as data collected from in-person clinical assessments and blood work, including labs and lab measurements that are recorded as part of Recover. Other things that I wanted to note, the infected and uninfected groups are subject to misclassification. The infected participants included in the study are not required to have a test for SARS-CoV-2. They're not required to have antibodies demonstrating that they were infected with COVID. This was because very early on, of course, COVID testing was very difficult to come by. And so we did not want to exclude children who did not necessarily have a documented PCR test indicating a history of COVID. On the other hand, we also did not require children under the age of 2 to have antibody testing as part of Recover. And so it's possible that some uninfected children in the study may have actually been infected with COVID, but were perhaps asymptomatic. And so the caregiver had no idea that the child had COVID. And so they may have not had an antibody response. And so this was not part of the we were limited in how we could restrict the uninfected group. So there is some misclassification that is possible in this study that we wanted to note here. I think now I'll pass it back to Rachel to summarize some of the study implications.
Thank you so much, Tony. I wanted to talk kind of bigger about what these results what their implications are, and to start that, while we know these indices only had a few symptoms in them, to really highlight the slide that Tony shared, that it really helps to identify children that also had many other symptoms that don't contribute to the index themselves. And what we hope is that these findings will help clinicians, will help healthcare teams, will also help families by raising awareness about long COVID and showing that long COVID does exist in young children, and that the symptoms may look different from those that we're seeing in older children and adults. And that while these types of symptoms that we highlight may be common in young children and may be common in other illnesses, it's critically important that long COVID be considered. And really, some of our next steps are to understand why these age differences are happening so that we can better identify children across the ages with long COVID and work to create treatments for children across the different age groups. And so along with that, one thing I did also want to highlight is that along with this paper on early childhood that came out in JAMA Pediatrics is a JAMA pediatric patient page that was also published. And this is a free document that can be downloaded by anyone. It's one page, and it really highlights some of what long COVID is in a very clear way, and some of the different symptoms that we see across the 4 different age groups that we look at: infants, toddlers, preschool age children, school age children, and adolescents. And this is a document that can be shared widely with families, with healthcare teams, with schools, and we'll also be providing the link. And so just to conclude, building on this work, what are our next steps for Recover Pediatrics? And so building on what we're doing to characterize long COVID based on symptoms across the different ages, our next steps are to integrate the many different types of data that we're collecting and the data we're collecting over time. And so this will help us to further understand the different types of long COVID that we're seeing across the ages, and to really delve deep into what are the underlying mechanisms that are causing these different symptoms and different trajectories of long COVID over time. And so that we can ultimately identify targets for prevention and treatment and refine what we know about these research indices over time. And so I wanted to just end by highlighting that Recover is truly a collaborative effort. And we have so many people to thank, but particularly all of the participants and their families, all of the sites and staff around the country, the patient, caregiver, and community representatives that are involved in every part of Recover, our governance structure, the NIH for all of the funding and collaborative support. And this just highlights a few of the institutions that are involved in our core and main hub for the pediatric, but there are many institutions across the country. So thank you all so much, and I look forward to a further discussion.
Thank you so much, Dr. Gross, Dr. Tawitae. Next, for our next segment, we want to kind of take a slightly different approach and step away from the PowerPoint presentation. And we're going to be talking with 2 of our Recover representatives, Krista Coombs and Megan Carmilani. And I want to thank them both for taking the time to join us today. As you saw, Megan was one of the co-authors on that JAMA piece that Rachel had shared there. So we're going to dive in. We've got a couple questions to kind of kick things off, but welcome, Krista. Welcome, Megan.
Hi.
So, Both of you currently serve as representatives as part of the Recover Pediatric Observational Cohort. So, to help us orient our audience, can you talk about some of the reasons that you got involved in Recover? And Krista, why don't we start with you?
Sure. So I've been in Recover as a caregiver rep um, as my two kids and I all got sick in early 2020. So we learned about long COVID like 6 months after our symptoms started, which was in August of 2020 is when I first heard about it through Ed Yong's Atlantic article. And so then once we kind of learned that there was a name to this, this really started me always trying to find support for myself and for my kids, as well as helping other people with long COVID. In terms of coming into the Recover Initiative, I was in early support groups that had caregivers and families from all over the world. So this is like in 2020 and 2021. And I heard many stories early on about children not getting better after a COVID infection. And this was especially the case in the media in the UK and Italy. So I knew that there were so many kids and actually multiple family members who were affected by long COVID, either in the same household or the same family. So I knew that Recover was also seeking for people in the US to join the program. So that's when I sort of decided to join in. I thought that Recover might actually help me as well be able to advocate better and kind of give me more information about research and what the findings were and kind of help me have more credibility. One of the things that I really am doing is like constituent advocacy. So kind of working with Congress. So kind of taking what I learn and trying to talk to them. So.
Yeah.
Thank you.
So I got interested in joining Recover. Well, let me back up. So first I got interested in helping out with long COVID advocacy because when I was a child, I developed infection-associated conditions. So when I was 11, I had a mono infection, and from that I developed what I would later learn was POTS and ME/CFS and basically any infection-associated conditions, probably somewhere on my medical record at this point. And so early in the pandemic, I started connecting with families whose children were not recovering from COVID. And I was able to really relate to the children's experiences. And so from that, we ended up founding Long COVID Families, which is an organization that supports children with long COVID. And then when I heard about Recover, I was very much interested in getting involved and making sure that children were well represented in the research because they're often not given the attention they deserve. And I was very excited about the possibility of what Recover was doing, the size of the study, the quality of the study. And this really hasn't happened for children before. So I'm very excited to be a part of it.
I wonder, Megan, if you could expand a little bit on that from your perspective about what about the really the importance of this study and what makes this work so critical.
So, if everybody can remember back in 2020, we were initially told children weren't affected by COVID. And then we were told, there was even a period of time where there was a narrative out there that children couldn't even be infected. And then if they were infected, then they obviously recovered, and that children couldn't get long COVID. And these myths really were really, really persistent. And so when children were dealing with symptoms that were just as severe as what we were seeing in the adult population, there was no one really to go to for help, and families were very confused. And the difference between children and adults is that a child can't take themselves to a doctor. A child can't self-advocate. Children's symptoms have to be observed by an adult and understood, and the adult has to make the connection to COVID to understand it's long COVID, and then you have to go to a doctor. So it's a little bit of, lack of a better way of explaining it, telephone. So like a lot of information, the game of telephone gets lost in the path. And then it was already, even into 2023, there was like this massive collective denial about what was happening with children. And it wasn't until Recover started publishing that we started seeing a shift. And So, you know, in our community, we always say, thank goodness for Recover. Because it is what we saw a significant shift as soon as the first paper came out. Even this last paper with the early childhood, there's been a significant shift in families' ability to access support and care, or even be taken seriously.
I just wanted to jump in here about just young children and how the children in this study that we're talking about today were born during the pandemic, and that is a little bit different. So when we've been mostly talking about children, what I've been hearing is children all of a sudden are lazy and not wanting to go to school, like all these kind of tropes that you just hear over and over again. So kind of switching now to young children who haven't had any of those opportunities to say this is immunity debt, this is all these other reasons. That's what I think the importance of this study is, of just giving this research to this age group and looking at it and recognizing that this is really important too.
Thanks for sharing that. For kind of from the work that's been coming out, from the results that have been shared, what are some of the main concerns, questions, and needs that you're continuing to hear from families? What's continuing to echo?
Yeah. So we hear a lot from families that there is a concern about how often the children are getting sick, and how severe the symptoms are when they are sick, and how long they stay sick. You know, so we consistently hear from families, especially in younger children, that it just, they'll say things like, you know, this isn't what my eldest went through, something's different. You know, they'll make those comparisons of just the kids are sick a lot. The other thing families are very concerned about, well, let me finish with the consistent with the illness, is that it's just, it's so disruptive. If you have multiple children and trying to, you can't go to school and you can't go to work, and it's, you know, and then there's like some rigidity in the school about how many absences can a child have. And children with long COVID, like they can get sick with just a cold and suddenly they're out for 10 days. And the school's calling them at day 5, you know, saying you're in violation of attendance. And their long COVID's not well known, so the doctor doesn't necessarily know to write a doctor's note for it, and it gets very complicated for families. The other thing families are very concerned about is, you know, developmental delays. We're seeing, you know, we get lots of questions at long COVID families about, you know, my child doesn't seem to be speaking like you would expect at this age, or they're not walking, or they seem to be kind of not developing quite at the same pace as their peers or what was expected. You know, and I think in both cases, they'll go to the doctor and be told it's normal. And then what happens is that a couple years go by, and then suddenly they're in kindergarten and they're compared to their peers, and then they're told it's not normal. And that gets very frustrating for families because they tend to pick it up. I think everybody's trying to reassure them that it's going to be fine. But what happens when you focus on reassuring and not actually addressing the concern is that you miss the window for early intervention. And that's part of what families are very concerned about. I'm sure Krista actually probably has more to say about that.
Yeah, I mean, what is coming to me is kind of like we have to live underground because nobody wants to hear us talk about COVID, and let alone long COVID still. There's a lot of isolation and loneliness among children who have been kind of left out, who are trying to get better, don't understand why they're being treated this way, families not understanding why they're being treated this way. I mean, who really wants to say they have long COVID at this point as a kid? And I'm just thinking about raising children who can't have any pride in like their disabilities and who they are from an early age, just really it's just really detrimental. So what I've been hearing a lot of is just there's a lot of fear. There's fear, is my child going to get better? Is my child going to get worse? What's going to happen with this next infection? I'm getting sick all the time too because my child is bringing things home. And so there's another part of this too, is just the families themselves are getting sick a lot. Yeah. So if you have anything more, Megan, on that, I think we could talk about this one for a really long
Yeah.
time.
Yeah. Well, kind of moving towards the action oriented around what would you say is most important for pediatricians and other pediatric healthcare providers to know and to do um, at this point?
I think it's important. First, we're still, the understanding that children can develop long COVID. Parents are still being told it's rare. Parents are still being told it's not likely to have happened. And they have certain preconceptions based on adult symptoms of what it should look like. So it's often dismissed in children as not a possibility. Um, the the other thing is that, I think we're operating still a bit on a pre-pandemic mindset and expectation of what we see in children. You know, people don't expect children to develop chronic illness. People have an assumption that children get an infection and they recover. Um, and it's just not the way it is anymore. And so, the first instinct is to blame development, right? Of like, well, a child's growing, kids develop at different rates. Puberty is often blamed. Um, and it's meant to be reassuring, as I said previously. But when you're a parent, an image of a mom's face is coming into my head because I had this conversation with somebody about a year ago, and she said that her child was almost 2 years old. And I just met her in the community where I live, just happened to meet her. She found out I ran an organization for kids with long COVID. And I just remember she paused and her eyes kind of welled up. And she said, I didn't know children could get long COVID. And I said, yeah. And I started explaining it. And she said, I know my son never got better after his COVID infection. And she said, I tried to talk to the pediatrician about it, but he told me not to worry. And at this point, she's crying. She's like, I knew something was wrong. And she said, she asked me do you think this could be long COVID? And I said, well, it's not appropriate for me to say. I can't diagnose, but I think, if you're concerned, the nearest hospital to us that really has long COVID clinics, Children's National, which requires a drive, which requires a hotel stay, which requires, quite a financial commitment to get there. But she went and got diagnosed with long COVID. And she got back to me afterwards and said just the relief, because it was crazy making that what she was experiencing and seeing in her child and the concern and fear that she just instinctively felt kept getting dismissed by doctors and her family and, even the daycare. And that how much better she just felt to at least know what it was. And that she could do, at least knew there were some things she could do to help her child.
Yeah, for me, I just think that pediatricians and pediatric health providers need to realize that this is actually part of their job now. They need to look at their biases of like why they're kind of resistant to including this, to educating themselves. There's things like the NASM definition that they can look at. They need to schedule like follow-up appointments really soon, not leave parents and families hanging there, do telehealth to make things easier. There's lots of things, make connections in the household, whether there an infection happened recently and maybe tying it to why there's residual issues happening or new symptoms, worsening conditions. Those are the things that I kind of see. Having this JAMA patient page is another tool too that can help.
All right, and thanks to Jennifer for dropping that link into the chat there. If folks have other questions, they can put those over into the Q&A. More broadly, from your perspective, what does this mean in the bigger picture? What are the implications of the study findings at the broader, more societal level? And Krista, let's start with you.
It's a hard one for me because of where we are right now. And also, I guess, understanding how we think about children or not think about children or people who are pregnant in our country. So I don't really know, other than it can't just be patients and caregivers and dealing with this. We need more support from other people raising awareness and educating. I mean, that's what we're doing today, but it has to be within Congress. It has to be bigger, it has to be schools getting involved, workplaces getting involved, doing simple things to protect children, because we are talking about our future health, our vascular health, our brain health. So we should be doing things to help protect the air, clean the air, not just from COVID, but all the other things happening. So that's kind of what I see. But I'm also like really, if you talked to me about this a year ago, I would have probably really different things to say than right now. I'm feeling a little stuck with this idea of how things move forward.
Yeah. I would just add, I'm actually a former teacher. I'm a reading specialist by training. So I worked with children typically who had disabilities. And so my immediate thought just at the scale of this, and, we're estimating 6 million children. And the rate of infection that's still happening, our numbers are still growing. I immediately think about the impact it's going to have on schools. And that our system is not prepared for it. Long COVID is a dynamic disability where symptoms fluctuate, and our school system is mostly built around the idea of a fixed disability, where symptoms are pretty consistent. And so the school system's really not designed for millions of children coming with dynamic needs. And it is a rough situation, and it unfortunately will continue to be for a while.
All right, well, thank you, Megan, Krista, and to our presenters. And looking at the clock, we've got about 30 more minutes left. So I want to bring in our discussant, Dr. Salisbury, to help bring together today's presentation and the conversations that we've just had around long COVID and young children. And Dr. Salisbury, welcome. And I know you've got some questions to share for our panel today.
Hi, everyone. Thank you. That was an incredible presentation by everyone. It was really nice to hear it all together. I was really impressed just at how well you brought together how important it is that we are doing this study, that we're researching long COVID across the lifespan so that we can really see the differences developmentally and how that might change over time, because our children, and some of them in our cohort, are actually becoming adults. So it's been really nice to think about it from that lifespan perspective. And I also think, as you were talking about, how we've really come a long way from those days when people were even questioning if children got COVID, never mind long COVID, right? We kind of had this development along the way, and you're here today bringing us so much rich information. So thank you for that. And seeing the results summarized together, I think really highlights the need to consider these developmental changes and the different needs across the age groups. And that, I think that also came out in the presentations and what you've discussed. And for me, as someone who also studies sleep, I was really, it's notable that there's a consistency of sleep symptoms across the age groups and even in adults, but it looks different depending on the age of the child. And so I think that's something that stands out for me, is something for us to follow up on. And so, Rachel and Tony, you really talked about what's next for Recover from a broad perspective. I'm wondering if you can share with us on what Recover Pediatrics is doing now, and what the plans are going forward for longitudinal plans for children, and what's happening now and what's next.
Yeah, thank you so much for that question. So there are so many things happening in Recover Pediatrics. And when I mentioned in the beginning the broader aims, we're looking at so many of these different factors at the same time so that we can learn as much as we can. And so the research we presented today is fundamental in being able to understand which children are experiencing the different symptoms at the different age. And building on this, we are following a large group of the children in Recover for up to 4 years, and hopefully longer, to be able to understand how symptoms are changing over time. So that's one of the first things that we're looking at is children have symptoms that are persisting for a long time. Some children's symptoms are improving, but they may be coming back and coming and going. And so studying this change of symptoms over time can also give us a lot of information. Then we're looking at factors that are related to having long COVID symptoms or having different types of long COVID symptoms, or also having different trajectories of symptoms over time. So what clinical factors might be contributing to this, what social factors might be contributing to this to help us understand the underlying mechanisms. And so to understand why these differences are happening will also be things that we're looking at. So we're starting to look at, changes in the immune system and how that might be relating to what we're seeing. We're looking at vaccination, we're looking at other social factors, and be able to also look at biologic factors. So are there genetics, other exposures that might be related to this, so we can identify the underlying mechanisms.
Yeah, I would just add that so the results that we presented today were really just focused on, a single visit that a large number of children and their caregivers completed that only use symptom data. But in Recover, there's so much data that's collected in the longitudinal phase, as Rachel mentioned, and we're able to kind of incorporate, we continue to ask about the symptoms that are being experienced, but can integrate clinical assessments, including labs, and other things that measure, learning ability, more behavioral related assessments that can help paint a higher dimensional picture of what's going on with children as they age, rather than just like what symptoms are they reporting through their caregiver. And so yeah, there are many ongoing projects related to neurocognitive outcomes, dysautonomia related outcomes, a deeper dive into sleep related outcomes that are actively being worked on. And we hope to be able to share at future R3 seminars going forward.
Right, so a lot going on, and it's only just beginning to come out and to be analyzed what we're finding and discovering, and I think that changes every day, but it's hopeful. And Kristen, Megan, you shared so much rich, powerful information with us. I thank you for that. I learned a lot from listening to you, and I really enjoy working with both of you on this study and getting your input. Um, I'm wondering if you can share with us what resources and support are available for families and caregivers now.
Sure. So Long COVID Families is a nonprofit that I'm associated with. Our website is actually just our name, longcovidfamilies.org. We can share that link in a little bit. So we have information on there, specifically our mission centers around accelerating research. So we share a lot of information about the research. Access to education and access to medical care. So we do have a page dedicated to, because I saw there was a question about that too, like 504 plans, IEPs, things like that. I have, former experience being on an IEP team. So we have a lot of information about that. And then we have information about accessing medical care. We don't have a group right now that's active. We're in development of it. So we're adding there'll be a discussion forum kind of way for families to connect. That's on an app that's independent from like social media that's coming. Hopefully we'll have that up within the next two months or so. But if you sign up for like our newsletter, you'll get that kind of information. And then we are hosting Pediatric Long COVID Awareness Week. July 21st. There's information on our website about that as well, with several toolkits and ways for families to get involved, or other organizations can get involved. And then if you are, within the public health field, there's a toolkit for you as well. We're hoping, as Krista said earlier, that, children really need the community at large to get involved. Yeah, I know Krista has more resources.
Yeah, thank you, Megan. And I'm really excited about the week coming up, advocacy for pediatric long COVID. So for me, I can't say enough about word of mouth referrals, and finding people within your same state, finding caregivers with kids around the same age, who can direct you the best right now, like finding a medical professional that might be worth seeing that's within an area that you can get to possibly, and also help with navigating all the education needs while being sick as a kid, and that there's just so many of us here to help families that I just wanted to kind of just put that out there. Like, I think we're your best resource right now. And please find us and keep asking questions. Let's keep working on this together until the rest of the world catches up, hopefully.
Excellent resources. And finally, is what's important for schools to understand? What's the most important thing?
So the most important thing for schools to understand is that long COVID's an umbrella term. There isn't just one presentation, right, of symptoms and experience. That's my door, sorry. So it could present in a number of different ways. I often hear from schools about, well, we're not medical providers, we don't diagnose. And the reason they're saying that is because most children with long COVID do not have a diagnosis. And my response always to schools is that we're not looking for you to diagnose it. We're just looking for you to identify what symptoms are impairing a child's ability to learn. Right. And so, and then address and accommodate those symptoms. So, and what I would say to schools is, like, if you see a child that's disengaged, if you see a child that's irritable, if you see a child that may seem like they're dysregulated and they're lashing out in class, things, at this point, we need to stop and ask, could it be long COVID? Because a child's not going to say, I have a migraine oftentimes, therefore, when you asked me to do something, I snapped at you. Kids don't really have that ability. I mean, I was a kid, and I was a very irritable kid because I was in a lot of pain, right? I had infection-associated conditions. I was irritable a lot. I didn't make the connection between the fact that I was in pain and that I was talking back to my parents. I wasn't making that connection. We need the adults to kind of get curious about why children might be behaving this way, if they're falling asleep in class, things of that nature. Let's just not assume they're bad kids.
Right, really important point that not all children have the ability, especially developmentally, to tell us how they're feeling and what that might mean. Great. I thank you for all of this, and I think we've got a lot of questions from everyone else. So I'll send it back to you, Christine, to help with the Q&A.
All right, thank you. And yeah, we are quickly moving through our time today. So we're going to open it up to the questions that we have from our audience. We've got quite a few in the Q&A there, along with a few questions that we've received in advance. Since we're likely to run out of time, just a reminder that we're going to also post a Q&A document on recovercovid.org. And Jennifer, thank you so much for dropping in that link to the longcovidfamilies.org that Megan shared, so you can go there for some of those resources that were mentioned. All right, so kind of jumping into these. We've got a lot of questions that over in the Q&A around taste and smell. And so to Tony and Rachel, from all of the data that's been collected, has there been, what are the types of data that you have that can help identify children's abilities to taste and smell? Tony, you mentioned this was a cluster that came up with adolescents, but how can we see this in the data that you guys have collected?
Yeah, thank you. This is such an important question. And for me, what it begins to highlight is now our next step is to understand why we're seeing the symptoms that we see across the different ages. And so for me, when I look at the symptoms that we see in the infants and toddlers, and people mention this in the chat, and as poor appetite or trouble sleeping or, things that caregivers can observe as something that they see in their baby. The question is, why are we seeing these symptoms? Because the babies we know don't have the verbal ability to share with us that maybe it's because their smell and taste is changing and that's why they want to eat. Or maybe it's more related to how their stomach is feeling. Like we don't know why. We just know that these are the symptoms that are being expressed that caregivers can see, and they're more likely to be long COVID. And so our next steps are to understand these are the types of symptoms that are being observed. What are the underlying things? And so it leads us to ask that question about smell and taste in younger kids. As a result, we are working to see how can we add more specific tests to actually objectively test smell and maybe taste in young children. And so as a result, we're going to look and see if that's something that we can begin to start to study as we've learned these things about the young children. It is interesting that the adolescents do report a high level of loss in smell and taste. So do the adults. Even our school-age children that's not being reported as much. It doesn't mean that it's not there. It may be that the kids with vomiting and stomach pain, they also have change in taste. We don't know yet, but that's what part of the work to understand will be. Christine, you're on mute.
Thank you. As it notified me of that as well. So other variables that are in the data set, Tony, you mentioned around the uninfected, and this was mentioned as a limitation there. When a lot of COVID-19 infections were asymptomatic, how does that really complicate looking at these symptoms, like taste and smell, but also the others between the infected versus the uninfected groups in this analysis? Can you just kind of expand a little bit more on that?
Yeah, so one result that we didn't have time to share is that we did look at amongst three. So in Recover, antibody data was not collected for children under the age of 2 for safety reasons as well as other reasons. And so there are limitations to what our results can show in that age group. But we did look at a sensitivity analysis looking at uninfected 3 to 5-year-olds who did have antibody data and were confirmed negative versus those who had missing antibody data. And we found that the results were quite similar in terms of the rates of reaching the long COVID research index threshold for being long COVID probable in both groups. So we don't think that our results were very sensitive or that the results are impacted greatly by potential misclassification here on the presence or the absence of having antibody data, because our results were robust, even if we looked at children for whom we could not officially confirm that they had never been infected. I think that more broadly, certainly asymptomatic infection is something to that's very tricky to study, but we know that it's still possible for a child to develop long COVID, even if they were asymptomatic during the initial phase of infection. This is something that's been observed in adults and children and all of Recover, that it's not only children who were, or people who were sick during the, or very sick during the acute phase who end up developing long COVID-like symptoms. I think that's something else that we've been very mindful of in analyses as being, that and that's largely because symptoms are only one way that long COVID can manifest. In some cases, it's the most common way, but that's not necessarily always going to be the case, which is why so many future analyses that are going to come out of Recover are looking at clinical assessments that don't require symptoms, which are, of course, subjective, subject to recall bias, but looking at more objective clinical measures in the population that is followed longitudinally to better understand the relationship between long COVID and potentially asymptomatic presentations of long COVID.
All right, thanks for that. The next question is around reinfection. And we've got a couple of those around kids who are still going to school in person, the effect that these have on the symptom severity over time, the dynamics that were being mentioned. What effects are you seeing in the data, or is it something that you've been able to look at for the data, and then also for families, bringing in Megan and Krista from the other side around being able to manage those?
Yeah, so just for what we're able to look at and recover, this is something that is very important, we know, to the community and to the development of long COVID, and it's something that we will be looking at. We do collect information when families enroll in the study about how many COVID infections they believe their child had when they enrolled, as well as we collect that information every 6 to 12 months at each of the visits. So we will do our best to be able to look at reinfection over time. We have not started that yet, but that is something that we're definitely going to be looking at. I'll turn it over to Megan and Krista to talk more about that as well.
Yeah, so we definitely see the impact of reinfections within the community. So what we were seeing initially when children would develop long COVID, a certain percentage, and I don't know the number exactly because this is just community observation, but there was a significant pattern of children that would eventually improve or even report being recover within, say, 1.5 to 2 years. What we have found, though, is that upon reinfection, there would be a major setback, and it was like recovery never happened. So it's almost, because of reinfections, it's almost wiped out the hope of recovery for many in our community. And because children are in schools, there's not a lot of control over exposure to infection. Even if a child would wear a mask every day and wore it perfectly, they still have to eat. Right. So a lot of families, this is a real source of despair, honestly, with families. They feel like they don't have any control. There's a lot of places that are very hostile to anybody trying to take precautions about infection. There's some school districts that will not allow you. There's some school districts that will not allow virtual learning. So in many cases, the only way a family can protect themselves from reinfection is to pull their kid in homeschool. And that takes a certain level of financial privilege that many do not have. And so it's a very, like I said, it's despair is what families feel, in the sense of it's completely outside of our control.
Yeah, for me, just what feels a little left out here is a reinfection can also cause long COVID. So someone might be okay enough, or maybe they had a little bit of a longer infection and then the reinfection could really take them down. So this picture is just really complicated and it's changing all the time. There's really no baseline for cumulative infections and what that does. Other than we've learned with adults, it seems to create a lot more problems. So I'm imagining that's true with children as well.
Yeah, and I'll just add, our numbers are still growing as far as children with long COVID. So we saw the first major wave of children after Omicron. We will start hearing from families typically about 3 to 6 months after the infection, because it takes families a little bit to realize that it's long COVID and that, the child's not recovering. And so we saw the first wave of families contacting us, in the spring following Omicron. But at this point, almost every child's had at least one infection. So it's almost all reinfections at this point. And after every wave, we still see an influx of kids.
Mhm.
So
does it make to this group, does it make a difference if the child's received the COVID vaccination, and if it, is there any difference in the types of vaccinations, or is it just that the effects of vaccination and infection?
So someone else can speak to the data, but what we see in the community that's getting complicated. Well, actually, why don't someone speak to the data and then I'll add what I was going to add.
Sure, I can comment briefly. So this is the subject of much ongoing work in Recover about the effect of vaccinations. We do know, first and foremost, that vaccines prevent getting COVID. And so if you prevent COVID, that prevents long COVID in all the ways that we've discussed already today. And so several Recover electronic health records studies have demonstrated that being vaccinated can prevent the development of long COVID. So while we're still working on demonstrating on these studies that are looking at it in the specific cohort that we've been describing today, many electronic health records and other cohort studies have demonstrated that vaccination can prevent long COVID either by preventing primary infection or perhaps through other mechanisms by even if somebody did develop COVID, that there can still be a secondary effect of preventing long COVID.
All right. Well, that takes us to our time. So unfortunately, we're going to need to wrap up. We do have upcoming sessions that we know that this is probably going to be a continued discussion. So as we close out, I want to say thank you so much to our presenters and thank you to our audience for attending today and really engaging with the Q&A. As a reminder, the recording of today's seminar is going to be available on recovercovid.org. It'll be there in a couple weeks. And we'll also post a Q&A document that has responses to the questions that we've received today, including some of those that we didn't have time to address. So if you didn't hear an answer to your question or see a written response, be sure to look there and that information will be shared out. Before we conclude, just a quick reminder to our researchers, both within and beyond the Recover Initiative, you can now apply to use Recover data to be able to get to look into the data here for ancillary studies. It includes all 3 of our cohorts, adults, including pregnancy, adults, pediatric autopsy. There's biospecimens that have been collected from all of the cohort participants. So there's more information online. I keep repeating this again, but heading over to recovercovid.org/ancillary. So you can submit your proposal and receive approval and letter of support if you're seeking funding. You do need to have your independent funding support to conduct that proposal, but you can check that out for more information. And coming up next, we've got our future R3 seminars. Also, if there's topics that you'd like to see covered, please take a moment to enter those into the pop-up that has appeared in front of you. It asks for your feedback on today's session. So we appreciate if you could just take a minute to fill that out. All right. This concludes today's R3 seminar. We thank you and hope that you have a great day.